Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and independently sponsored by Amgen.
This program is presented by Medscape Education Global.
Hello, I'm Vicky Lee. I'm an ophthalmologist based in London. Welcome to this activity, Thyroid Eye Disease, how to use targeted immunotherapy in clinical practice. I'm delighted to be joined today by Mario Salvi, an endocrinologist at a joint endocrinology ophthalmology clinic in Milan, Italy, and Don Kikawa, an ophthalmic surgeon based in San Diego, California. Thyroid eye disease, or TED, is a disfiguring and often visually disabling condition that can have profound psychosocial and economical impact on our patients, including increased risk of patients taking their own lives. The goal of thyroid eye treatment is to reverse and prevent these changes and improve our patients' quality of life. TED can be a very heterogeneous disease between different ethnic groups and between patients. Most patients report distressing changes in their appearance, and about a third have disabling visual symptoms and soft tissue disease. Sight-threatening disease ranges from 2% in some studies to over 10% from a recent study in Southeast Asia. Our recent US IRIS registry found the incidence of sight-threatening disease to be about 18%. So if you look at these slides, all these patients from different ethnic groups have sight-threatening disease with apparently low clinical activity score, which makes the diagnosis and sometimes treatment much more challenging. It is also worthwhile remembering that the so-called upper limits of normal proptosis can vary between different ethnic groups as well, and the ATA, American Thyroid Association 2015 guidelines, define different upper limits of normal between males and females of different ethnic groups. So in practice, it's best to ask your patient what has changed and compare their current appearance to their pre-morbid photographs. So at this stage, I'm going to ask a question from Mario. What are some of the routes through which patients arrive at a TED diagnosis?
Well, certainly, thank you, Vicky. Certainly, one of the main route of access for the care of these patients is through the endocrine clinic. There are clinics in major hospitals in which patients are seen because they are followed because they develop thyroid dysfunction, especially Graves' disease, which is mostly associated with the disease. And we still don't know why only 40 to 50% of patients with Graves' disease develop a thyroid eye disease, but it's certainly mandatory if we want to take really good care of this patient is to ask all of patients with Graves' disease if they do feel any changes in their eyes. Sometimes they're very, very minimal and they're very early in the appearance of the disease. But I think it's important that we do see these patients very carefully because sometimes the ocular symptoms are very subtle, as you just showed before, but the patients do perceive that there is change in their eyes. So they have to be asked consistently. Then if there is suspect for any eye changes that may be related to the disease, then the second step is to refer patients possibly to a joint thyroid eye clinic, if available anyway, to an ophthalmologist who is actually expert in seeing this patient and can really try to assess any early changes or any specific changes for this disease.
Great. done. So once the patient is seen by an ophthalmologist, how should they be assessed?
Well, thank you, Vicky. So good to be with you and Mario discussing this challenging disease that we have all spent the better part of our careers treating. It's an excellent question. First, we need to do a very thorough eye exam, checking for visual function, visual acuity, color perception, motility. And then, specific to thyroid eye disease, we need to assess both disease activity as well as severity. Clinical activity score was first described by Martin Moritz back in the 1980s, and although it's not perfect, it has been validated in several clinical trials. Clinical activity score consists of 7 initial points. 2 of them are subjective, followed by 5 objective points based on inflammation, swelling, and redness of the eye. These are 3 examples of patients spanning the gamut of mild, moderate, and severe. And while CAS and disease severity don't always mirror themselves, in this particular set of patients, they do. The first patient is what I would describe as mild thyroid eye disease. There's less than 3 millimeters of proptosis. And it's also important to assess the patient burden. This patient has no eye problems. The CAS was decided to be 1 based on just a little bit of eyelid swelling. The patient in the middle has moderate thyroid eye disease, a change of proptosis of greater than 3 millimeters. The patient burden is assessed to be moderate. Patient's eyes really bother them. The CAS of 5 corresponds to eyelid swelling, erythema, injection, chemosis, pain at rest, and pain on eye movement. The patient on the right has severe thyroid eye disease. 2 additional points on the clinical activity score are given for the caruncular edema, which is noted on the inner aspect of the eye, as well as the severity of which the eyelid swelling occurs. The table is taken from the American Thyroid Association grading of mild, moderate, and severe thyroid eye disease. If you look at the central column, the deciding feature is mainly based on proptosis. Mild is less than 3 millimeters, moderate to severe, greater than 3. And then we have the soft tissue involvement, which can be moderate in those moderate patients and severe in the severe patients. The last category is reserved for sight threatening. So it's really incumbent upon the eye specialist to do a thorough visual function analysis as well as grade for clinical activity and severity.
Thank you very much. Mario, can you show us an example case of a moderate to severe TED and how you would manage this patient, please?
Okay, moderate to severe TED really represent a very wide range of different presenting diseases because, as it was has already been mentioned also, but the disease usually is characterized by a clear proptosis of the eye, which is usually more than 3 millimeters. This is one of the main features associated to diplopia. But the presentation can be with clearly inflammatory signs, like the first picture in the slide, with soft tissue swelling, the important soft tissue swelling, and the second patient shown in this slide as well. You see again even more swelling of the lids and redness, as it was reported in the clinical activity score. But then you have pictures like the last 2 of this slide, in which you really see the eyes totally out of the line. So the patient is diplopia, has strabismus, and there's very little inflammation. In one patient, there is some swelling of the eyelid. In the second patient, there's practically none. So all these patients are encompassed in the range of moderate severe disease, but they really do deserve different treatment based on their presentation. When inflammation prevails, of soft tissue inflammation prevails, certainly one of the objective is to try to decrease that as soon as possible, because that is a sign of disease progression. The problem is more when you don't have inflammation that is not doesn't help you in assessing if the disease progresses or not, And then you have to rely on other signs, which are the assessment of motility and see how the motility changes, the assessment of proptosis and see how the proptosis changes in the various subsequent assessment you do. So based on these different things, we have to think about different treatment. The UGOGO has produced these guidelines in which first-line treatment is usually mostly steroid related treatment and controls very well inflammation. But if steroids fail, we have to think about second-line treatment. And among the various treatment available, you see the teprotumumab, rituximab, tocilizumab. Teprotumumab, unfortunately, in Europe has not been available up until now, so it's not being used. So the alternative is either to associate orbital therapy to steroids or another course of steroids with either immunosuppressants or go to the monoclonal antibodies. These guidelines have been produced in 2021, but the following year, the European and the American Thyroid Association went together to produce a consensus document of the approach, which has differently approached the disease based on what we were saying before about the different presentation of the disease. Here, the approach was to really try to target the dominant feature of the disease and to suggest which drugs or which treatment are fit better for that specific dominant feature.
Don, can you show me a case example how you would put these guidelines into practice?
Yes, of course. So this is an interesting subset of patients that may initially respond to steroids and then have a incomplete response or recur. We used to go straight to surgery with these patients, but now we do have other options available. This is an example of a 45-year-old female. The burden of how the disease affecting her is high. She can't work due to painful eyes. She stopped seeing her friends and socializing. She was diagnosed with Graves' disease 2 years ago. She's currently on methimazole. She's a non-smoker. She was treated 1 year ago with IV pulsed steroids at an outside center. Currently, her visual acuity is 20/20. Her exophthalmometry is 22 in the right eye, 21 on the left eye. We judged her clinical activity score to be 6. So she has pain on eye movement, lid swelling, lid erythema, conjunctival injection, and chemosis. Here's her imaging, which shows diffusely enlarged extraocular muscles. And on MRI T2 signaling, she does have high signal intensity of her inferior medial rectus. So our analysis, she has moderate thyroid eye disease with active symptoms. She has large muscles. Her CAS is elevated. Her personal burden is high. And this is where we might have some discussion on the treatment options for this patient. She's already had steroids. She recurred. Some physicians would go to radiation, orbital decompression, off-label biologics, and now in the U.S. we do have teprotumumab available. What are your thoughts on this case, Vicky and Mario?
Mario, would you like to go first?
Yes, certainly. I would not actually repeat steroids for sure because she failed on that. So I would go either for off-label biologics or teprotumumab for sure. Having available teprotumumab, I think this would be a good candidate for that. And not having that available in Europe, I would opt now probably for tocilizumab, as tocilizumab has shown more than the rituximab some effect also on proptosis and on diplopia as well.
I agree with Mario. You have to treat the inflammation and let it go quiescent. Also, in view of her thyroid status, she's still taking thyroid medication. It's very important to also establish with her endocrinologist what her long-term thyroid plan is in terms of planning for future. But having teprotumumab means that actually there's no urgency to sort out the thyroid, and she can stay on medication for a while and see whether that works. But failing that, tocilizumab would probably be the best option.
So we elected to proceed with teprotumumab for this patient. She did receive 8 infusions. She had a 4 millimeter proptosis reduction. Her clinical activity score did decrease to 0. She did have some mild side effects of nausea and cramping that resolved as the treatment ended.
So, what are some of the features that will make you think that a patient is suitable for approved targeted immunotherapy when you have access to these drugs?
Yeah, I think as Mario mentioned, we need to decide what is the primary reason why we're treating patients. I think if we're looking for proptosis reduction, particularly in those patients with large muscles, I think my experience mirrors the clinical trials. You're probably going to get a very decent proptosis reduction. Up to 82.9% of patients showed a 2 millimeter reduction. The average proptosis reduction was about 3.5 millimeters. There was improved extraocular motility as judged by the Gorman scale. Soft tissue inflammation, as judged by the CAS clinical activity score, also reduced. Most importantly, quality of life, as a study by the Graves Orthopathy Quality of Life validated studies showed improvement. So the side effect profile is also manageable, which is something we will discuss later. And optic neuropathy is something that we've seen here in the US, where some practitioners are proceeding straight to teprotumumab as primary therapy for optic neuropathy. Getting back to the combined HTA/ETA guidelines, of which Dr. Salvi was a co-author on the study, I find that the table is very good for looking at specific ways that we treat certain aspects of the disease. And after looking at this table for many hours, I find that it's better kind of to look at the bottom up. So if we look at the statement of the treatment goals, lid retraction, we typically are going to wait till the patient reaches the inactive phase and offer lid surgery. We can give botulinum toxin or perhaps subconjunctival steroids to help with that. If we want to improve eye motility, we would treat medically with IV steroids, possibly radiation therapy, or teprotumumab. Non-surgical options would include occlusion or prisms, and then in the inactive phase, we would perform strabismus surgery. For reduction of proptosis, the two options for medical therapy would be teprotumumab, as seen in our patient that we just showed, or traditionally, we would offer surgical decompression. For disease inactivation and reduction of proptosis, we have teprotumumab or radiation therapy combined with IV or oral glucocorticoids. And then for disease inactivation, we have several options: steroids, off-label biologics, as well as radiation and teprotumumab.
So, Mario, we also have these off-label options that Don mentioned. What are they, and what is their place in therapy?
Well, rituximab has been studied as the first biologic in this disease, and the nice effect that was shown in rituximab was that the patient had very rapid inactivation of disease. Unfortunately, the only two studies available have conflicting results because in one study, the Italian study, in which rituximab was compared to steroids, showed to be superior than steroids in inactivating disease with very few relapses. And whereas the study conducted in America did not show superiority of rituximab versus placebo. Tocilizumab has been studied in a control study a few years ago by some Spanish colleagues, and they show very nicely in activation of disease, at least in the very early phases of disease. And they also did show some important reduction of fructosis, which was not though confirmed in later study and later on in the trial. We recently have concluded that at a multicenter trial in Italy in which we compared tocilizumab to steroid. Some preliminary data were presented that are very interesting. Tocilizumab does inactivate disease and does also have an effect on proptosis and diplopia. Other immunosuppressants have been used, but in combination with steroids, not alone. And I do not think that these are going to have much space, especially if the patient do not respond to steroids in the first place.
Don, what happens if we don't have access to any of these treatments? What else is available?
Well, traditionally, we've advised all of our patients to stop smoking. There have been some clinical trials looking at the use of selenium in mild thyroid eye disease. We can give botulinum toxin to hyperactive extraocular muscles, for example, patients that have a large hypotropia or esotropia. We can deliver that directly to the muscles. Peribulbar steroids have been shown in some studies to have a beneficial effect. So this is a long-acting steroid given as a peribulbar injection, which does have some improvement of inflammation as well as strabismus, stress reduction, and then a question mark for the role of surgical thyroidectomy. I think there may be one or two studies that, from a epidemiologic standpoint, do show some improvement of thyroid eye disease if the patients do have a surgical thyroidectomy.
Thank you. And so, how has the introduction of targeted therapy changed your surgical practice in any way?
Yeah, well, I think when this medication teprotumumab first was introduced, we saw a dramatic reduction of our surgical decompression. So this is a study that we published in the Canadian Journal of Ophthalmology, looking at the number of decompressions that were performed at our center. So the data starts in 2016 and then it goes to 2020. You can see a fairly constant number were performed for the first 4 years. We see a dramatic drop off in 2020, which coincidentally was also when the pandemic hit. So you could argue some of that was from the pandemic. However, we have carried it out for 3 additional years. And while we have seen a bump up in the number of decompressions, still it has not reached the pre launch era. So I think it has diminished the amount of surgery as well as the volume that is performed. Um, One thing that we do see with teprotumumab that I have not seen with other modalities is the dramatic reduction of muscle size. So this is a patient who had a CT pre and post Tepro, and you can see that there's been a marked reduction of the size and caliber of the rectus muscles. And before we might have seen it as the inflammation quelled, there might have been some small reduction, but these muscles do really reduce in size, which is something that I have not seen with other modalities.
Great. So, Mario, can you sort of describe the types of patients in which steroid treatment is still appropriate, please?
Well, we do still use steroids, and also with successfully in patients with I would say moderate disease without mm, relevant proptosis and relevant or just I would say very early onset of disease, even with diplopia, and they do respond. Some of the patients do respond significantly, especially in terms of improving the diplopia. Sometimes diplopia disappears after steroids if the patients are treated very early. The lack of effect of proptosis is known. So, as I say, I would reserve steroids to patients very early in the course of disease before all these feature appears, because we do know that steroids are very good in inactivating disease, but the impact on the reduction of proptosis is really not evident. Also, the type of patients in which we definitely use steroids as first line, and that really does change the outcome of diseases in patients with severe disease, with optic neuropathy. Actually, we do submit patient to a course of steroids before orbital decompression, and the response is usually very significant. About 40% of patients do respond, and some patients do really, in some patients, we really do spare orbital decompression surgery as well.
Just to comment on the steroid that Mario made, we're finding that if we can get teprotumumab, we will use that as first line therapy. So we may even use it even before steroids because I feel like the sooner that we're able to offer the soft tissue and activation and with apoptosis reduction, the better. Maybe in some cases where we have optic neuropathy, we might still treat with steroids as bridge therapy, but we will try and prescribe teprotumumab when available. In
Thank you. And Don, what are the really difficult patients that you find the most challenging to manage?
Yeah, I think these are problematic in any practice, Vicky. I think these patients are ones that need really multimodal therapy. We may do radiation in some patients. We might do surgery combined with teprotumumab, and then maybe some patients still also need immunosuppression with some of the off-label agents that Mario discussed. Certainly, any smokers, we encourage them to stop smoking. That sometimes helps with that also.
Don, can I ask whether you will use teprotumumab for sight-threatening disease over steroids?
We will. We might bridge them, Vicky. So if we see patients with dense optic neuropathy, we might give them 1 or 2 doses of IV pulse therapy, and then typically we can get teprotumumab on board fairly soon after. If it's a more mild case, we might treat them with oral steroids. So it really depends on the depth of the optic neuropathy.
Thank you. So can you describe some of the common side effects of these targeted therapies and how would you manage them, please?
Yeah, this is a from the phase 3 optic trial of teprotumumab, and it really divided the common side effects in the placebo group as well as the treatment group. And you can see that potential adverse reactions to the infusion were very much the same in both groups. There was no evidence of anaphylaxis. Hyperglycemia does need to be monitored in patients that are prone to diabetics. So we do check a finger stick glucose. Muscle spasm is probably the most common thing that's seen usually in relation to the infusion time, and it lasts for several days in the large muscles of the calf or the thigh. Diarrhea was seen in both groups, and hearing impairment was seen in 10% of the teprotumumab group. And that's the one that I think patients are most cautious about. We do have to warn them if they have any hearing symptoms that we do monitor them. So our experience is that we do mirror pretty much the side effects that were seen in the phase 2 and phase 3 clinical trials. We do get a baseline audiogram. It's also important to counsel what type of hearing symptoms patients may have. Tinnitus, autophony, where you hear your own voice, muffled hearing, and then certainly the sensory neural one, which we do check an audiogram for. We also need to be cautious in women of childbearing age, so we check a beta HCG and urine testing before every infusion. Women are cautioned to be on mandatory contraception because teprotumumab is a teratogen. Less than 5% of patients stop treatment. What we're seeing is that about 30% of patients do have some reactivation or flare after the initial treatment and may need retreatment. This was seen in the Optic X trial that was published back in 2022. However, the majority of these patients do have what's less than a 2 millimeter recurrence in the proptosis and may not need retreatment.
Many thanks. Does the retreatment usually work to restore them back to their initial response
It
generally?
does. I've
Mhm.
retreated several patients, and it does have a very similar improvement effect on proptosis, and the side effect profile is also very similar.
Perfect. In conclusion, our recommendations are to follow the guidelines for patient assessment and treatment, be always patient-centered and individualized care, and treat the dominant features of their disease. Be always alert that patients can develop sight-threatening disease, and also work closely with the endocrinologist to ensure that the thyroid condition is managed. And that emphasizes the need for multidisciplinary care of this condition to make treatment a success. So I would like to thank Mario and Don for this discussion. It's been really enlightening.
Thank you, Vicky. Thank you, Mario. It's been a wonderful session discussing this difficult disease with both of you.
And to thank you for your attention and to continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.